delighted to say for our latest podcast edition at Top Doctors UK, I'm joined by highly esteemed radiotherapy specialist and clinical oncologist, Dr. Richard Shaffer, and highly esteemed plastic and cosmetic surgeon, Mr. Ioannis Goutos, to discuss keloid scars for today's podcast session. And so, Dr. Shaffer and Mr. Goutos, before the questions, if you'd like to provide some background information regarding your medical careers.
Yes, maybe I will make a start in that. So thank you very much for inviting me, and thank you for the introduction. I'm Ioannis Goutos. I'm a plastic surgeon, and I have a specialist interest in managing scars. I'm very proud to have been in collaboration with Richard for really just under a decade now. And really, we have what I feel come to a very international standard protocol to manage very challenging keloid scars. So maybe it's time for Richard to do his own introduction.
Sure. Just to take you a little bit further back in what I've done, I'm trained as a clinical oncologist, so to treat cancer with chemotherapy and radiotherapy. But about 5 or 6 years ago, I focused my career on just treating benign conditions with radiotherapy. And I've treated probably 3,000 patients for all sorts of conditions. And keloids is one of the ones, of course, that I do with Mr. Goutos, and one which I find particularly interesting. We've set up a service where I think we think of this as a whole pathway approach, and that's one of the things that I'd like to bring out in this podcast.
Fantastic. Thank you very much to you both for the background information. And obviously, you both are very skilled and you have expertise with regarding keloid scars. So I'll jump to you, Mr. Goutos, first. For our first question, could you briefly explain what exactly keloid scars are and how you personally encounter them on a daily basis?
So there are really a number of different definitions of keloid scars. And if we were to be quite critical about what really is a keloid scar, it is quite difficult to define. But in most cases, the way that patients will present to us with keloid scarring is, first of all, significant bulk. So these are scars that are well above the surface. Sometimes they can be so bulky that they form a mushroom-like mass on top of the skin. They tend to be quite troublesome. Sometimes they give patients a lot of itch. They give a lot of pain. And clearly, in most cases, patients will present with appearance-related concerns. Those scars are very unsightly, and also their behavior is quite unpredictable. So some patients will develop them without an obvious original injury to the skin, or sometimes the injury to the skin was a long time ago, and then it takes a lot of years for them to develop a troublesome scar. So this is really the majority of ways that people with keloid scars will present to us.
Excellent. Thank you very, very much, Mr. Goutos, for that. I suppose, Dr. Schaffer as well, how would you personally encounter them? Would it be similar to Mr. Goutos's case?
Well, I guess I see them in two ways. Some of the patients, perhaps the majority of the patients, actually come from Mr. Goutos, and he's seen them and talked about the various treatments that one could offer for keloid scars, some of which are going to be non-surgical, which no doubt he'll go through in this podcast, but some of which, of course, will involve excision and some sort of treatment after the excision, one of which is radiotherapy. So some will come to me from Mr. Goutos where he's decided to do an excision, and then we discuss radiotherapy before that process happens. Some patients, however, come to me where they've got a keloid scar, they're just not sure what to do, and they ask my advice. And over the years working with Mr. Goutos, I've got a sort of feeling for the sort of keloids that may well need excision and therefore radiotherapy, and for some keloids that actually don't necessarily need that. Sometimes people mislabel things as keloid scars where they're hypertrophic but don't necessarily need, the same sort of management. And sometimes, people aren't necessarily looking for the keloid to be taken off. It can just be flattened with various treatments. And so I think that's one of the things that I've learned over our partnership. And of course, if they do need any of these treatments, whether it's excision or whether it's non-excision, I would then send that to Mr. Goutos.
Fantastic. It's great to hear the collaboration between you both and the process. So it's very, very clear for patients. First step, Mr. Goutos, for the evaluation, and then to be referred to yourself, Dr. Shaffer, which is a great, great to know about the teamwork between you both. And then staying then with you, Dr. Shaffer, for question 2. And can you give us some specific examples with regards to where on the body patients typically get keloids and what sort of problems they can cause?
Yeah, so I think the most common place for people to get keloids is often associated with the ear. So often people have an ear piercing and then eventually they develop a lump. If the lump's small, it might not need treatment, but if sometimes it becomes very protuberant, like what Mr. Goutos was talking about in terms of a sort of mushroom sort of idea, and then, it can do a few things. First of all, it can be very tender if it brushes against something, but of course there is going to be a cosmetic impact for a lot of people, and they really just want to have it removed. On the earlobe in particular, actually they do well with excision and perhaps just a steroid injection, although I do give radiotherapy for quite a lot of these as well. But in other areas, they can have a greater chance of coming back. And you really need to do the whole pathway, so the surgery, all the other treatments after that, including radiotherapy, extremely scrupulously. And what I mean by that is if any of the part of the pathway goes wrong, then you increase the chance of recurrence. And so, for instance, we've treated patients who've had keloids on the front of their chest, called a butterfly keloid, which can sometimes be from a really trivial thing like acne or chickenpox, or sometimes from something more substantial like some surgery, for instance, cardiac surgery. Sometimes we see them over the abdomen. For instance, I saw one with from cesarean section. Sometimes actually on the breasts from breast operations. Sometimes on the neck. Really we see them in all these areas, and particularly where they're under a lot of tension, they can have a particularly high chance of recurrence. So we do see a variety. I think because I guess we regard ourselves as a tertiary referral clinic, we tend to see the particularly tricky ones. I suspect that there's thousands of patients who have much easier ear keloids that never sort of come as far as us. But actually, therefore, we see the really hard ones, and we're very used to dealing with these complex cases.
Very interesting you touched there, Dr. Schaffer, on the complex cases. So, Mr. Goutos, what would your specific treatment options be? And does it depend on on a patient basis, or how would you treat your treatment options?
So there are really quite a number of different approaches. And as Richard said, as essentially a private tertiary protocolized system, because we actually have a very systematic way of assessing and treating patients, we look at keloids in a much more systemic manner. So, for example, when patients will come for a consultation, we're going to cover the characteristics of the keloids, the symptoms, the location, and what the priorities for treatment are. So some patients would just like the scars to be flat. Some patients would like the scars to be removed, so they go from a scar that is raised to a flatter scar. So The consultations we do are really quite lengthy and they explore those. Then we really look at what happens to the rest of the body. So very frequently, patients with keloid scars will have a number of conditions, for example, high blood pressure or excess weight or polycystic ovaries and irregularities in their hormonal balances. And actually, unless you address those and make sure that their metabolism is optimized, these patients have a much higher risk of having their keloids back. So once we've done all this, then we talk to patients regarding two main options: either flattening the scars or removing the scars with surgery. So these are the two categories. When it comes to flattening treatments, these can be divided into things that we apply on the keloid. For example, for keloids that are not too bulky, we can use steroid tape, which is a very minimally invasive option. Sometimes we can inject steroids and then combine that with the tape. These are ideal for small keloid scars. When we go into scars that are a bit bulkier, we might need to use lasers and then combine them with the steroids. And there are also some other treatments that include cryotherapy, so you can actually freeze keloids off. But if patients will come to us and say, look, I have been through all those flattening treatments and really I'm aiming for something more of a radical solution, then we will discuss about removal of the keloid. And then in the overwhelming majority of situations, then Richard will need to do his magic with the radiotherapy. Because if you just simply remove a keloid scar and do nothing, the chances of it coming back is well above 80%. That's not a good statistic to kind of play with. Whereas if you remove a keloid scar and then do radiotherapy, the risk of it coming back, based on our joint experience, is about 5%. And this is very consistent with international standards of care.
Fantastic, Mr. Goutos. And you touched there on Dr. Shaffer's approach then to radiotherapy. So, Dr. Shaffer, radiation therapy is sometimes used to prevent keloid regrowth, as Mr. Goutos just mentioned. Can you explain how that works in terms of after the surgical removal and what aspects you need to pay particular attention to in these cases?
Yeah, so this is all pre-planned. And part of what we do is coordinate so that the surgery and the radiotherapy are not too far apart. Because really, you've got a window of up to 3 days that you can start the radiotherapy after the surgery. After that, we know there's less of a chance that the radiotherapy is going to stop the keloid from coming back. So, sometimes we do it the day after, sometimes 2 days after, but sometimes 3 days after, depending on just how we can coordinate things. The next thing I think is something I've never really read about, but something that I think is really important is how the surgeon presents the scar. And so the way that Ioannis does it is he covers it over with essentially an elastoplast, so an opaque skin plaster, and then draws the area that he's been. And the great thing about that is that I don't have to remove the plaster. And I'm always worried if I have to remove that sort of adherent plaster that it's going to disturb the scar. And you sometimes find the scar doesn't hold together properly. And so that's been, a real issue. Different people do it in different ways. Some people leave it open, which is okay. But, I think you don't get the tension on, you don't get the effects of keeping the scar together from the plaster. And also you can get bleeding. Sometimes other people use a transparent dressing. But the problem is that you often see bleeding underneath the dressing, and it's really difficult to see where all the sort of stitch holes are. And if I don't cover them, then that's a potential site of recurrence. So this is why I really I like it, and actually, you know, when I have worked with other scar surgeons, that's always something that I talk to them about before I even accept the referral, because otherwise I just don't know what I'm going to get. You know, sometimes they put something on, I'm busy trying to take it off and really worrying that I'm going to be pulling on the scar. So that's the first thing: presentation of scar. And as well as that sort of opaque plaster, there'll be a looser dressing over there to stop bleeding on the clothes or on the bed sheets. So we take off the outer dressing and then we leave that dressing on. And that really tells me where he's been surgically, and he adds a margin onto that so that really I know that I'm covering everywhere where the skin has been pierced during surgery. And I'm not going to miss anything. And I use that as the basis to draw my radiotherapy field, in other words, where we're going to treat. I then also have to decide how deep to treat. And essentially, I want to cover the whole thickness of the skin, which tends to be, let's say, between 5 and 10 millimeters. But it does depend to an extent on where in the body I'm treating, because skin thickness actually does vary through the body. And I think that people in the past perhaps have treated too superficially, in other words, not deep enough. And that can be a source of failure. And then there's a period of complex calculations that we do, and we shield off the areas with lead that don't need to be treated. And then the treatment's given. The dose is a really important aspect as well. And some people just use one dose for any part of the body. The problem is, because I've already talked about areas that are more likely to recur and less likely to recur, the areas that are less likely to recur don't necessarily need such a high dose, and the areas that are more likely to recur may well need a higher dose. So I use what's called a risk-adapted approach based on the Japanese group led by Ray Ogawa, who basically uses a lower dose for earlobes in particular, a medium dose for ear auricle, and then a higher dose for all the other higher risk, probably because they are higher tension sites. And that really is the basis of how we do it. And then, so essentially it's one treatment, two treatments, or three treatments is what it comes down to. And so we deliver those treatments over 1, 2, or 3 days. And then I offer a follow-up. I would say, however, that follow-up is, again, something that people have missed out. And it may well be that Ioannis wants to add something, but what I would say is, if you're going to get recurrence of your keloid, that's going to happen within the first year or two. And so during that time, it's really important to keep an eye on the patient to give the best result. Because, you know, there is keloid recurrence, which is keloid becoming bulky and really needing to start again from the beginning, or there's a bit of thickening that can happen, which is salvageable. And so you can turn a potential keloid recurrence into an actual success by being followed up properly and by having a salvage treatment. And so I always tell my patients that's a really important part of the process. It's not just the surgery, it's not just the radiotherapy, it's also the follow-up and potential other treatments. And Ioannis, I don't know whether you want to add something about that.
Yeah, I totally agree. And one of the things that we make very clear in both our consultations, that if someone decides to undertake treatment for a keloid, this is a major project. It's a major project that needs commitment, needs investment, and there is no other way around it. So what I would add to what Richard said is that from the surgical point of view, I will see patients following the surgery and the therapy. I will remove the sutures myself so that I have as much control over the wound as I can. So that when I remove the sutures, there's very, very minimal extra trauma to the skin. And then I will personally see them at month number 1, 3, 6, and 12. And clearly, if they have any concerns in between, of course, I will see them as a follow-up. At each of these points of time, there are going to be specific things that we will be looking for. and then guiding patients as to what the right step is. And that could be either using a paper tape or steroid tape or having some additional lasers or treatments so that we decrease the amount of inflammation or angriness within the skin, because this is what keloids love. They love inflammation, they love angriness within the tissue. So, I totally agree about, the kind of the specific, the real significance of follow-up.
Fantastic, Mr. Goutos. And Dr. Shaffer, we just heard there Mr. Goutos' specific approach then to follow-ups for patients. Would your approach be similar, or would you both be very mindful of the collaboration process?
I mean, the way I see it is that really the major issues for the patient are under Mr. Goutos. So the surgery has to be done meticulously, and I'm sure he'll talk about, with tension relieving approach, removing the whole keloid, all that sort of thing. The follow-up really I leave to Mr. Goutos, because all the things that happen in follow-up, i.e. the treatments that are going to make it less likely that the keloid will come back, are treatments that Mr. Goutos does. I don't do injections. I don't do lasers. I could probably do steroid tape, but the point is that these are really treatments that he will do. And, if the salvage treatments are under his care, then I really feel that it's better for him to both assess and treat as necessary.
Fantastic to you both. And then the last question then, obviously you both have a lot of experience and expertise with regards to keloid scars. And then talking about the past, do you both notice a difference in recurrence rates? And how does treatment nowadays help keloid scars not appear as much or not recur as much as maybe in the past?
So maybe I'll start off by my experience in terms of our pathway over the last really number of years. And what I have learned from my experience is that we need to be as assertive and as meticulous in the follow-up from the very, very early stage. So, for example, when I started up as a surgeon, then if, for example, someone would come to their 3-month follow-up and there was a little bit of redness in the scar, I would allow that. But now, if I do see signs of inflammation or angriness, then I have no hesitation to treat that. Because what I have learned is that the earlier that I tame the inflammation down, the better my long-term outcome would be. This is, I think, the biggest lesson that I have learned working with Richard through a very standardized manner. So we have a very set protocol that follows international standards. So because we have a highly protocolized care pathway, then I can see what minor changes can do to the final outcome. So from my point of view, this would be my biggest lesson really out of our collaboration.
Yeah, and I would add something that's changed for me, actually. And this, I think, is just a matter of time and experience. So I think when I first started treating patients for non-cancer conditions with radiotherapy, I felt very cautious about it. The prevailing wisdom was that really it wasn't something that people did. And anything that was other than, let's say, an earlobe was considered to be high risk and therefore shouldn't be attempted. Now, I've basically staked my whole career on treating patients with non-cancer conditions. So I treat osteoarthritis, tendinopathy, Dupuytren's disease, plantar fasciitis, all these things. And, the more I get into it and the more I think about it, the more I think about this as just a balance between benefits and risks. And so there are people that are very absolute about what they would and wouldn't do. I think the important thing to say is that the risks are actually very low from radiotherapy. And, to be specific about that, the risks after the radiotherapy, a bit of skin redness and soreness and dryness, and eventually you do get a little bit of skin changes. It might be a bit darker, it might be a bit lighter. You might have some blood vessels, a little bit like when people drink, you get burst blood vessels on the face. They're called telangiectasia. Sometimes you get that, particularly if you've had steroid injections before to that area. So you get some minor skin changes. The thing that people worry about is that whenever you give radiation, you need to be careful about, are you going to be causing a cancer with radiation? And the answer is not really. So if I treat 100 centimeters of the skin squared, let's say a handful of skin, in someone who's, let's say, 45 years old, I would normally say there's a risk of skin cancer, a type of skin cancer that doesn't spread, of 0.1% lifetime risk. So that's 1 in 1,000. Now, if you compare that to your risk from the sun, just from going to Spain a couple of times a year on normal sunlight, that's probably about 10%. And so when we think about that risk, it's very, very tiny. And, so I think with regards to skin cancer, if you're very young, let's say you're 20, I might double that risk, so maybe 1 in 500. But, really, I hate to use the word trivial, but certainly very small is what I would say. So that's one thing that I've become very comfortable with, having treated about 3,000 patients for benign conditions with radiotherapy. The other thing is the risk of cancer in other regions. And, when I started doing this about 15 years ago, there were areas that were just sort of no-go areas. And I'll be specific. That was over the breast and over the sort of jaw and the neck. And that's because people said to me, there's a risk of breast cancer, the risk of thyroid cancer, you just can't do them. And of course, when we actually see patients and we talk to them about, what this is doing to them, and a lot of it is cosmetic, but not only. Sometimes, I've seen patients where it's between the breasts and it's causing an enormous amount of pain because of that. Or whether it's so disfiguring on the face that they're actually unable to show their face at work. So it doesn't just involve the way people look, it's very psychological, but also there can be real sort of painful and physical symptoms as well. And so basically you're weighing up the potential benefits you can give them by taking away those terrible sort of things that these scars are causing against a potential theoretical risk of, we talked about skin cancer, and then let's say you're, over the neck or over the breast. There is a risk, but actually, it's pretty undefinable and very, very small, and probably the same sort of level as what I've said. So it's always something I discuss. It's always something I'm very, very specific as much as I can be, reading the literature and trying to look at what these risks are. It's all written down on the form. People know exactly about it. And ultimately, I'm only treating adults, so everyone has, the ability to reason about these things and weigh out these small theoretical risks with these potential benefits from the scar that they definitely do have. And so these are the way for me that the conversations go now. I used to be much more cautious and a little bit more scared. I absolutely discuss this in detail with every single patient. But I'm very willing to have that discussion rather than just avoid it and say no.
Fantastic, Dr. Shaffer. A very, very good approach. And it's very interesting to see how things have changed thanks to modern approaches to treatment. And I would like to sincerely thank you both, Dr. Richard Shaffer and Mr. Ioannis Goutos, for your expert, detailed analysis of keloid scars and how they're treated nowadays, and your multidisciplinary teamwork approach and the process involved. So thank you very, very much to you both for your time.
Thank you.
Supporting the post.